Yes. Welcome back to Tokyo.
Thank you very much.
Yes.
Thank you for having me here today.
No worries. Thank you very much for coming. It's we met first time during the AADOCR and
ADOCR, yes, they changed the name,
right?
and I
Yeah.
still don't know how,
What
what's the
is it?
name, because we've been saying IADR so long time.
Right.
And I think they just changed like 2 years ago or something like that. Yeah.
But yeah, thank you very much for
Where
coming.
was it?
Portland, right?
Portland, yes,
Portland, yes.
Portland.
It was my first visit to Portland, and
me too,
I
yes.
I thought it was gonna be much colder, to be honest.
Yes,
But luckily it was.
it wasn't,
It wasn't.
yeah.
The weather was kind of nice. Okay, Saito-san,
Hi.
just can you introduce yourself, to us and to people who are watching and listening?
Sure. My name is Hanae Saito. I am born and raised in Japan, and I went to dental school in Japan. And after that, I went to United States, originally to study, and I wasn't interested in clinical dentistry at that time. So first thing I did was I did my master's in clinical research. So I thought I was gonna go to research as my career. And while I was helping the clinical research in New York University, where I did my master's, I met several periodontists. And some periodontists are known in the field of periodontics and implant dentistry. Stuart from Dennis Turner. So, one day they asked me, why don't you consider to be specialized? And they even asked me, which one do you like, periodontics or prosthodontics? And I never like workshop when I was in the dental school. And so I told them probably periodontics. And next thing I did, I applied for the periodontics program there, and I became a periodontist.
Not so many people kind of leave Japan to work in the States. Like, I think there are only a few people who do this, right?
Well, I said to my parents, it's gonna be 3 years,
Yeah.
and it's been 20 years.
It's been 20 years. Yeah, but what got you interested in like moving to the States though? Like, why did you wanna?
So, okay, early 2000, let's say clinical research, especially in the dentistry, was not, let's say, major or let's say organized yet in Japan. And especially when somebody wanted to study how to do the clinical research, how to run the clinical research. So I am also a certified clinical research coordinator. So, whenever I do the study, it is my catch to the, those sponsored company. If you give us the study, you don't have to hire a separated research coordinator.
Yeah. Wow. That is very interesting. So, like you said, like you chose periodontics because you don't like to do the wax up, right? So you've said like it's been 20 years since you've been in the States, kind of,
Yes.
doing periodontics.
There was a time I was in the research center, helping other people doing the research.
I see. What research do you like to do, or what research are you interested in doing?
So originally I wanted to do clinical research, which I didn't have much good idea. And, so I was like in the curriculum, they taught me, how the research ethics work and how the, protocol development works and how you actually run the clinical research and, what you're going to do once you have the data and the publication. So I started from clinical research, but somehow I was involved in some animal research and like a bench lab, both in vitro, in vivo researched so in a variety of things.
In the program there, now you're supervising some students.
Yes, I am currently a director of predoctoral periodontics, meaning that dental student in the field of periodontics, and I am also going to run the PerioPros program. Starting next year, we are currently interviewing the applicant, which is a postgraduate program.
Postgraduate program. I see. Yeah, going back and talking about the research you're doing. I attended one of your lectures, and you were mainly talking about bone grafting materials, right?
Yes.
So generally speaking, maybe experienced dentists already know this information, but for if we're talking to maybe young dentists, can you tell them as an educator what are bone grafts and why do we need these bone grafts in the dental practice?
Okay, so let's break in a few different topics.
Yeah.
So one thing about jawbone, especially the area where we call alveolar bone.
Yeah.
Something unique about that bone is once tooth is extracted, there will be a resorption or shrinkage, and not necessarily associated with the extraction. Sometimes we have the deficiency of the bone related to anatomy or periodontitis or few different reasons. So if we tried to grow back the bone, which usually doesn't happen naturally, so we need to go for some aids to bring the bone back. So that's the instance we would like to use something, including bone grafting materials. And the one thing I always emphasize whenever I give the bone grafting lecture to the dental student, that's the one of the area too many terminologies are used back and forth.
Yeah.
Because when we call it as a bone grafting, some of the bone grafting is actual bone from the human. But many times bone graft does not mean actual bone. There are some artificial bones, there are some processed bones, so sometimes we refer those as a bone substitute.
I see.
So as it said, bone substitute, we use those to create the bone. And another thing we many times forget is that bone substitute is not the bone. So we use that while bone is going to form.
Like you said, there are different types of bone substitutes.
Yes.
Right? What are the categories, generally speaking, that we are that bone substitutes?
Okay.
fall under?
So we long term we believe that patient own bone, which is called autogenous bone, as a gold standard. Which I'm gonna talk about a little later. But we also have some processed bone from human or animal, and we also have synthetic bones.
You mentioned human bone or
Autogenous
bone is the gold standard. Why, as long as this is the gold standard, why are other companies and people are trying to use it? What are the merits and demerits of using this as a bone grafting material?
The reason autogenous bone is considered a gold standard, it's from the living person. So whenever we harvest, there are more, let's say, living cellular component within
Within the bone itself.
within the bone.
Right. Regarding the merits and demerits of using it, obviously merits there's living components.
Yes.
Is there what are the demerits to using this kind of procedure?
To me, the biggest disadvantage is that we have to harvest it, meaning that, let's say if I'm doing the surgery in one molar, I have to look for somewhere else in that area, either in the mouth or outside of the mouth, where I take the bone from. So even I am treating one molar, patient will have additional trauma for me to just harvest the bone.
Right. And obviously when we operate on a new, site, then this site is susceptible to pain, to infection, to all these kinds of problems.
So, yes, so that's a really good point. There are always potential infection while we are handling.
Yeah.
And also, since this is patient own bone, sometimes body likes that bone too much. So sometimes resorption can happen because the bone, it's from yourself
Yeah.
and it's in there. So instead of staying there, sometimes it gets completely resolved. And we don't know when that happened and when that does not happen.
Okay.
So I think I consider those as a disadvantage.
I see.
And another thing is because it's from the same person, there will be a limitation on the amount.
Okay, moving on to the other types of bone substitutes, what are the merits of using one over the other one? What are the preferences? Maybe not just academically speaking, but in your own personal experience.
Sure. So, for example, I am a periodontist. So, I practice as well and see the patient referred by somebody else. And if I do the bone graft, and many times I wanna show the people what I did in the X-ray. So the material, some of the bone graft material can be seen in the X-ray right after we use. Some we're not gonna be able to see until bone substitute had a turnover and become actual bone. So some clinicians prefer the material can be seen in the X-ray right after they use the graft material. And, of course, there are many other, I almost think prerequisite for the bone grafting material because that has to work as a scaffold until bone formed in the area. So, handling, because let's say if you are doing the bone grafting very first time, very beginner, because I observed that in my resident, whenever they are doing first surgery, they take longer than somebody doing for 10 years. So if any graft material, if your working time is only 30 seconds, it's going to be very challenging.
Yeah, yes, probably. And when you mentioned the properties of the materials,
Yes.
right? We always hear these terms: bone induction material,
Yes,
bone
conduction material.
These what are these terms? Well, can you explain it to us in a simple way?
Yes. So we have, as you said, we have the property called osteoconductivity and osteoinductivity. So inductivity meaning that bone should be able to stimulate for the, let's say, for the cells like osteoblasts to come into the area. And osteoconductivity is more or less like the graft is staying just a scaffold until those osteoblasts comes in. So I always use an example when I explain this term to the dental student. So let's say you and your friend went to movie.
Yeah.
Okay, and the three of you went to a movie, and one guy sitting in the middle went to buy the popcorn. Okay, so if these two students sitting right side and left side of the guy went to get the popcorn, they are born, and the guy went to the popcorn is a grafting material. So he has to, he is the one
Yes,
in the
yeah.
middle.
The-
Yes.
the-
So what this middle guy's job to do is if this guy is osteoconductive guy, he just sitting there doing nothing, more or less like just waiting as a two student becomes a bone. But if he's osteoinductive, he's like poking both side friends. Hey, I'm waiting for you to become the bone.
I see.
And if it's like more or less like a osteogenesis, he can become the bone.
He can
Yeah.
produce the bones. Oh, very nice and easy to understand example. Nice.
I deal with dental students.
Nice. Yes. I never thought of it this way. Regarding the bone substitutes that you usually use in your practice or the one that you're interested in applying in your practice.
Yes.
What are the materials that interest you or materials that you prefer to work with?
I personally think we should have more than 2 or 3 different property. Sometimes you may have to have more than one kind of bone because the purpose you use a bone grafting material can be different. I would say at least we have 2 different purposes.
Okay.
So one is where you do something like alveolar ridge preservation when you extract a tooth and you want to place the implant later. In that time, you place the bone to form the bone, but you want to come back and place the implant within certain time frame.
Yeah.
So in that case, if you have the bone graft takes 3 years to become the bone,
Yeah.
you
Not so
want to have
yeah.
something a little sooner
Yeah.
or faster.
Yeah.
On the other hand, if we are placing the bone graft material somewhere like a sinus lift,
Yeah.
or sinus augmentation,
Yeah.
once you place the bone graft there, bone substitute there, you wanted to have that material stay there longer, pretty much forever.
Yeah.
So in that sense, you wanna go for the material, you know that resorption will be slower.
I
So, in that sense, you may want to go for 2 different material or, or if there are any, if there is any material can give you both property, then of course, everything will be solved. But if not, you may have to have this kind of bone for this indication, that kind of bone for the other indication.
in your department.
Yes.
You said like you place implants and you do I think
Periosurgery,
very
yes, yes.
different types of periosurgery. Like you mentioned, like if there are kind of freshly graduate students
Yes.
would have a little bit more difficulty dealing with the materials. So how do you make sure that do you ask them to work with all the materials and then they should know how to handle all of them, or do you just go for your go-to materials quite often?
I think one of the advantage of the residency is 3-year long is at least they can get to try different materials.
I see.
And one part of the doing the surgery is, of course, they have to do the surgical planning. So whenever they pick the bone grafting material, there has to be the reason why they pick that material. So department have more than one kind of material. Sometimes too many, but they should know what they are doing. So but if they are doing very fast surgery, I probably recommend them to use something with easier handling.
Easier handling.
So when I said easier handling, some bone substitute or bone grafting material is too plain as a texture. So if the material can give you a little bit of the stickiness, it's easier to handle.
Right. Yeah.
And if some material is too more or less like let's say if I have something like a sand versus something with a little stickier, which is easier to stay in place.
Yeah, obviously, like
Yeah.
When it's sticky, like
Like
you can
moldable.
shape it.
Yes.
Right? You can shape it a lot easier. I understand. I'm going to ask you about the carbonate apatite, for
Yes.
example, the material that GC is producing. Have you had the chance to work with it, and what do you think of it as a bone grafting material?
So yes, I had a chance to use by myself as well as had my resident tried, and I really liked the moldability, which means material. I wouldn't say too sticky, but it is. I think was very easy to handle.
Very easy to handle.
Yes.
But how do you use it? Like it's granules in nature,
It's granule,
right?
yes, and I believe it comes with 3 different sizes.
Yeah.
So if you are working somewhere small, let's say like a periodontal defect between the 2 molar roots, like like with under the furgation,
Yeah.
you can go for smaller size,
I see.
which is easier for you to pack all the way. And if you are working larger area, and especially where you would like to have more blood to come in, like a vasculature to come in, you can go for a larger size. So having those, variety as well as the handling allows you to do different cases.
The smaller sizes for the smaller defects.
Yes.
But like, do you have like a certain size of defect that you follow, or it's just like a kind of depends on your experience and how do you deal with these defects?
For around the tooth,
Yeah.
and if you have the extraction socket and the implant is there, and if you have to work in between the socket and implant, I probably go with the smaller sizes.
I see.
And if it's a guided bone regeneration
Yeah.
type defect, I'd probably go somewhere in between. Let's say if there's something called like a medium size, I probably go for the medium size. And something like sinus lift, I like larger particle. And some literature also support larger particle because larger particle means there are more space between the granule. And the space between the granule where blood goes in, which gives the nutrition to the grafting material. So that's gonna help the turnover.
As a material compared to, carbonate apatite, comparing it, for example, to hydroxyapatite, have you seen like different behavior of the materials in similar kinds of applications?
I did observe some difference, and unfortunately, my experience is still on the early side. I have not seen something like a 5-year result or 10-year result, but I really like the initial response of the soft tissue.
The nature of the soft tissue.
Soft tissue. I think the material is very soft tissue friendly, let's say, because many times when we do smaller surgery like alveolar ridge preservation, socket preservation, sometimes membrane can be gone within week or so. Because sometimes, those membrane is done as an open kind of environment.
Yeah.
So graft material can touch the soft tissue directly after 7 to 10 days of the surgery.
Yeah.
And I think we've been seeing less inflammation in the soft tissue.
I see.
At least the cases we did in the University of Maryland.
Like you said, like if you want to go for a simple grafting material, you probably wouldn't go with an autograft, right? Like you probably want to go with a.
I probably use only once or twice a year. Autogenous.
Autogenous graft. So even though it's a gold standard, you
I
don't
do not
think it's
use
worth,
it.
the injury.
Yes, unless there is a need to do the other site
Yeah.
anyway, then I will do the autogenous graft. But if not, I try not to give the patient additional trauma.
Right? Yeah. You would say that you work with other types of grafts, other types of bone substitutes.
FDBA, DFDBA,
Right.
yes.
And for for the bone substitutes, like for the FDBA, right? Like what does that stand for?
Okay, so let me just actually go back a little bit.
Yeah.
So I think I mentioned that we have the bone from human origin bone
Yeah.
and animal origin bone
Yeah.
and artificial bone, right?
Yeah.
So we have the bone graft material called allograft, which is from human origin,
Yeah.
and the xenograft, which is from animal origin, and the, synthetic material.
Yeah.
And allograft has two different types: FDBA, which is a freeze dried bone allograft, and DFDBA, demineralized. Mineralized versus demineralized.
I see. And is there like a difference in using like which one? Like you said, like you ask your students to know which cases
Yes,
to use.
yes.
So hopefully we can help everyone, also learn this information.
Because it's demineralized and mineralized,
Yeah.
one is more thought to be more osteoinductive versus more osteoconductive. So nowadays, if you go to a dental meeting,
Yeah.
many people wants to use or wants to have both property. Many people mix the bone.
Mix them.
Yes.
I see.
So some people like to mix FDBA and the DFDBA, or some people like to mix allograft and xenograft. So, people nowadays getting more greedy. So everybody wants to have a little bit of property.
The best of
yes,
both worlds.
Yes.
Kind of thing. As for materials, for
Yes.
example, like allograft versus xenografts
Graft or synthetic, yes.
or synthetic bone, are there like merits to using one over the other one? Like you said, like some people mix it due to merits or in one side and versus the other one. What would be the merits, like for example, for the allografts compared to artificial?
So the reality is that if you wanted to use more material, that can actually cost, or you have to open more than one package.
Okay.
So many times people choose by their primary preference, like which one can give you more scaffold, which one can give you more cellular activity like osteoconductivity or osteoinductivity.
I see. Does the artificial materials like solve a problem that we cannot achieve with the, like, let's say, decellularized bones? I know that there is still some risk in kind of, since they are from human or even from animal origin, that sometimes there are problems associated with this.
Yes, some people still worry about potential, let's say, infection.
Yeah.
And another thing is the resorption rate is really not something we can control. Of course, once we place intraorally in the mouth, saliva, bacteria, and everybody have a different pH. So even we think material can stay for 5 months, sometimes that resorb faster than we expected. Those things can happen.
Yeah.
So synthetic material, I think those are in more controlled environment because it's synthetic. I think the resorption rate we can more, let's say, count on, how long it's gonna take to turn over
Compared to
let's say, allograft.
allograft. Well, thank you very much, doctor, for all the information you shared with us today. I welcome back to Japan. I know this is your house, but how cold is it now in the States? Is it much colder than here?
It's pretty much same as here. Like the beginning of December was really cold, like -6 Celsius. But the day I was leaving was like 8 or 10 Celsius.
Today I woke up and I saw it was -1.
Yes.
I was like, this is going to be a cold
Yes,
day.
Tokyo is cold today.
Yeah, right. But yeah, thank you very much for visiting us today, and hopefully
Thank
we're
you for
going to
having
meet you
me.
very soon. Thank you.